All right, so now we're going to talk about you know, the weaning of sedation and stuff like that. So I'm going to start by talking about analgosedation, right? There is a concept called analgosedation, and if analgosedation was a man, I would have killed it, just for the sake of our patients. But it's not a man; it's an idea. So we can't do anything about it. So basically, analgosedation is actually the way. Unfortunately, I can tell you, a good percentage of the tertiary care centers are using for sedation. If I describe it to you, it might sound familiar, which is basically base fentanyl drip for intubated patients, and Versed on top of it, Versed boluses, right? You know, it's done in certain hospitals. Very smart people are using it, and I think by a I think it's a major mistake. But let me tell you how we arrived at it, so you understand. And then after we arrived at it, somebody coined the name analgosedation. Okay, so basically, initially we were there are studies. It's like the perfect storm. There was studies that were done on a BIS monitor, and using also RAS scores, like sedation studies, agitation, sedation studies. People trying to find why are we having, you know, when the patient is agitated, what's the most common reason for the patient to become agitated on the vent? So let's talk about the BIS monitor because it's more objective than the RAS score. So this is the BIS monitor. You have a number here. That number is basically your BIS score. BIS is bispectral analysis. It actually goes here. It's like a 4 electrode EEG on the frontal lobe only. And what it does is that it's a processed EEG. It gives you a number, and that number is how awake you are. And if you're between 40 and 60, if the cardiac surgeons use that, they will be much better. If you're between 40 and 60, guaranteed you're not gonna have any recall. If you're above 60, you're awake. You might have some recall. If you're below 40, you're too much. That's like deep coma here. So that's one box here. The next box next to it, it's called the EMG, and the EMG has boxes like this, like a cell phone, you know, kind of a tower. And basically, if you have like one of them or two of them that is orange, or that means that you're having EMG, meaning that you're having contraction of these muscles, and that means you're having pain, you're frowning, right? Obviously, if you're doing like this, then everything is not believable, right? It's not true. But if you're like patient is stable like this, and we see that he's agitated every once in a while and not moving his head, then you look at this, and the nurse can objectively, whether you believe it or not, I believe it 100% actually. There's no, but I tell you why some people don't believe it. So basically, the nurse can look at this number and see that the patient is sedated enough or not, and if it's not sedated enough, to give him more Versed based on this number. If it's more than 60, or give him more propofol. You know, it will affect this number. Ketamine will affect this number. Etomidate will affect this number. But narcotics won't affect this number. Opioids will not affect this number. The EMG is affected by opioids. You give him fentanyl, the EMG goes down. So that's how the nurse here in this ICU is, you know, manages, you know, both sedation and pain, right? And then there's another box here just to be complete. This is like your actual EEG itself. So if you can see actually flat lines, I mean, you can't diagnose EEG from here, but you can easily see flat lines, and you can also easily see status epilepticus, right? And here, of course, is a big box that tells you the trend of your number. Okay, so this BIS monitor, it actually was introduced first in anesthesia, and the whole idea is that to prevent recall under anesthesia. Anesthesiologists used it for a decade or something, and then they rejected it. The reason they rejected it is most of the time, and I used it in anesthesia, most of the time as an anesthesiologist, if you compare classic teaching, turn the gas on and turn this to how much, 1 Mach, half Mach, whatever, all of these things. If you use it based on your classic, if you give anesthesia based on your classic training, or using the BIS, you find yourself cutting down a lot on your anesthetics that you're giving. if you use the BIS. So the anesthesiologist says, come on, that doesn't prevent recall. That just documents recall. It doesn't prevent recall, you know, because I'm cutting on everything. So that tells me that people who had recall either did the, you know, the cardiac surgery technique, which is wrong, nobody does it anymore, or they slept. You know, the anesthesiologist slept probably and forgot to turn the gas on. He's not going to tell anybody that he forgot to turn the gas on, but that's what happened. The patient heard everything, right? So, so that's why when you do that, you know, they found that they're cutting down. And if you're a vigilant anesthesiologist, you're never going to have a recall because you're giving much more than what the BIS wants, right? So that's what was rejected in anesthesia. But I received it with open arms because that's what we wanted in the ICU. We want to reduce the amount of sedation and we want the patient to be on the awake side even, right? So that's why we use it in the ICU. I don't know why people don't use it except that the studies are not, you know, glamorous about it. Anyway, going back to our perfect storm, this thing here, they looked at the BIS and in other studies they looked at the RAS and they tried to find out what happened. In that era, which is like 10 years ago or something, people were using mainly Ativan drips in the ICU or Versed drips. No fentanyl at all. Like we were taught that the patient is not having pain. This patient, who's a medical patient, doesn't have surgery. He doesn't have pain. Why would you give him any fentanyl? So we're not giving any fentanyl for those patients. And what happened is that they found patients like those are agitated. They have a good number, right, 50 or something, but they have EMG. So that means that we are underdosing the fentanyl. That these patients have some sort of discomfort from being in the bed, from being in the tube, blah, 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 that they have to have some fentanyl. So that's the first storm. People said it has to be that we, you know, that we need more fentanyl. Okay? That's the first storm. The second storm, I call it nosocomial. Anything that has nosocomial, any word that has nosocomial before it, Medicare doesn't pay, including nosocomial delirium. So people don't like nosocomial delirium. And what is the crude material for nosocomial delirium is benzos. Benzos, oh, you're like, there's nothing worse than benzos for nosocomial delirium, right? Maybe, and steroids. Huh? but nosocomial delirium, so obviously people got like, oh, okay, we don't want to use Versed. So that's the second storm. And then the third storm came from a study that came in 2006. There was, I mean, obviously, and all the stuff that came after it. In 2006, that's where the whole thing started about that storm here. Somebody came up with a landmark trial, who I keep telling you guys multiple times before. It's the rat trial where he took rats and intubated them and ventilated them for 2 days without paralysis, just sedated them. And 2 days, and took over the ventilation. He kept the vent keeps on doing like this. They're not initiating any breath. They just, at the end of the 2 days, he took their diaphragms and looked under the microscope and found there is necrosis of some of the diaphragmatic myofibrils, right? Meaning it's like the heart. If you go on pump for 4 hours or 2 hours even, 4 hours is too long. You go to 2 hours on pump, the heart is not coming back. He's gonna tell you, okay, you wanna do it yourself, you do it. I am not coming back. You know, I'm used to like beating all my life, and he stopped me for 2 hours, I'm not coming back. Very difficult. Same thing to diaphragm. You take over for 2 hours, for 2 days. That's what we do when we're not looking at the vent. When we do that, you take over, like this. And 2 days later, the diaphragm is so weak, and you say, why is the patient so weak? Critical care myopathy. No, it's not, you're an idiot. That's not critical care myopathy. Anyway, so what he did, he found that, so from that study came that, oh, we need to keep the patients a little bit more awake. And we need to have them do their own work on the vent and stuff like that. And then the rest is history. You've seen the studies where patients walking with an endotracheal tube. You've seen, you know, all of these things, which there's some fallacies to it and stuff like that. But you know, it's a true movement, right? That we need to keep the patients, you know, awake, more awake. And with that true movement, something has to happen. So they came up with bolus sedation. As a result of that, people said, okay, we're going to use bolus sedation only. Bolus sedation fell on its face because the nurse is impractical, right? Number one, it's too cruel. I'll never wish it on anybody to have only bolus sedation and you wake up in the middle. That's really bad. But in general, bolus sedation, let's say we're going to do it. The nurse is not going to leave the room when the patient is agitated, during the agitation of the patient, and say, wait, don't pull your endotracheal tube. I'm going to go to the Omnicell to give you some Versed. And of course, nobody's allowing the nurses to have Versed in their pockets, right? So it's impossible to be done. So most hospitals said, okay, well, bolus sedation is not going to work. So we need to go back. We need to find some drip that will do a baseline there. And of course, they looked for the drip. They're afraid of this. This told us to use a little bit more fentanyl. They made a huge mistake and said the drip is going to be fentanyl. For what? What are you treating with the fentanyl? What is the pain that is requiring a non-PRN, continuous, high dose, drip fentanyl as if you're a surgical patient, right? And then after like years of this, and people's like, that sounds very eerie. That sounds exactly what the cardiac surgeons did it for 50 years, exactly, right? And they said, okay, we'll call it analgosedation. And he came up with a review article about it, and then it became like kind of legitimate or legitimized. But it's the worst thing that you can do for your patients. Moving forward a little bit, I'm going to tell you a little more about why fentanyl in this situation is bad. So, for example, I'll give you some examples and maybe we'll talk about it more. Fentanyl is the worst medication as far as weaning from any of the medication that we use, right? Compared to Ativan, compared to Versed, it's the worst medication coming out of the body after infusion, right? And also fentanyl in these high doses causes ileus, so that you don't tolerate the tube feeds. Also fentanyl at these high doses will make you become an addict later. And also, if you try to, like they did in the cardiac surgery, if you try to control an anxiety with something that doesn't treat an anxiety, you will end up using very, very, very high doses. I know a hospital that actually uses up to 300 mics of fentanyl per hour. 300 mics of fentanyl per hour not for medical patients, not for surgical patients, for medical patients, right? 300 mics per hour, that you're gonna reach to a fentanyl dose in 10 hours. 10 hours you reach that dose that the cardiac surgeons were given. In order I've given 8 milligram of Narcan for patients to wake up from a dose like this after 10 days of on event, right? 8 milligram of Narcan is this is for accidental overdose. We're treating, this is a prescribed medication, and it's like an accidental overdose. This is horrible, right? It accumulates. I'll explain in a second. So what is the volume of distribution of fentanyl? Like, tell me any number. Volume distribution in a 70-kilo man. 200 liters. Like more than your body. That's the calculation. Volume distribution is done by calculation, or isotope or whatever, and they calculate it. That's more than your body, meaning what? That fentanyl fills every single cell of your body. It goes in your skin, in your nails, in your hairs, in your everywhere, brain, everything. It fills everything and comes out of you also, like exudes out of your body. Like if you touch me, you're gonna get sleepy. That's why when they touch the people who have carfentanil overdose, they get sleepy because it's just coming out. Everything is coming out of you. It's huge volume of distribution, which makes fentanyl an ideal medication for what? For a bolus dose. That's why if I'm walking around running, not even paying attention, and I say, the 102-year-old patient who's in room 16 is having pain, give her 50 of fentanyl. I'm comfortable giving her because I know she's gonna just wake up. Even if it's an overdose for her, she's gonna wake up in a half hour or so, right? But try to actually drip this medication for a long time. So half-life of fentanyl is about 4 hours or so, but the duration of action is a half hour. So try to drip it; it accumulates. I'll give you another example that will actually makes you understand this example. Amiodarone. What's the half-life of amiodarone? Very long, 75 days, right? That's the half-life, of duration of action of amiodarone. Okay, so why don't we just give amiodarone bolus until the patient see me in my office in 75 days and give him another one? And every 75 days, give him a dose. Why?
Volume distribution is low.
because volume distribution is huge. We have to fill the volume of distribution. So that's why we're dripping it. So the half-life or the duration of action of amiodarone in the first day is actually 2 hours. So that's why you're dripping it. And then if you, during the drip or during the first day or two, the patient is still having AFib or has another burst, you give him another bolus, because we didn't until you reach to 10-gram cumulative dose, which roughly about 1 day of infusion and then 7 days of 400 TID. That's 10 days cumulative dose, right? And when you reach that, then it's 75 days, the duration of action. And that's why I always wonder why some cardiologists sometimes they get 400 TID and then they go 400 BID and then 400 daily and then 200. You don't need to do that. It's already saturated the sites. You know, you just go from 400 TID to 200 daily after this and you're done. The point I want to make is same thing with fentanyl. It's a short-acting medication, but once you actually infuse it for days and days and days at these doses, then you reach to a point where it saturates all the sites and it scans everything and you can't take it out. It's very, very difficult to remove. And that is it.